Hello everyone, Matt Calkins here. Thanks for watching Module 3. In this final lecture of Module 3, we will shift gears from nutrition to the clinical application and measurement of insulin resistance, including how it can change your practice. First, my disclosures. I'm an investigator in a study that utilizes continuous glucose monitors that are provided by Abbott. This is a short lecture with a brief agenda. We will briefly dive more in depth on why measuring insulin resistance is important. We will discuss how to measure insulin resistance and how it can change your management in clinic. First, I wanted to review this article published in January 2021 in JAMA Cardiology that compared over 50 anthropomorphic measurements and metabolic markers to heart disease. This data was taken from the Women's Health Study, which had a total of just over 28,000 subjects. The median follow-up time was 21.4 years, with baseline data obtained in 1993 and patient follow-up through 2017. As a caveat, this is epidemiological data, which is non-causal and is only hypothesis generating, as you learned in Module 1. However, this exposure data is not based on food frequency questionnaires, but rather metabolic markers. Therefore, the measurement of these exposures by laboratory methods is more precise than survey data. The specific outcomes were first MI, percutaneous coronary intervention, coronary artery bypass graft, or CHD death. The authors investigated incident coronary heart disease during 4 different ages: less than 55, 55 to 64, 65 to 74, and greater than 75 years old. I altered the main figures of the articles to highlight the 5 risk factors below: diabetes, metabolic syndrome, LDL, triglyceride to HDL ratio, and lipoprotein insulin resistance, or LPIR score. LPIR is a risk factor that is a function of size and the number of the different lipoprotein particles, including HDL, LDL, and VLDL. Looking at only the coronary heart disease below the age of 55, meaning these women had primary outcome before they were 55 years old, diabetes had a 10.7 odds ratio, metabolic syndrome 6.1, LDL 1.4, triglyceride to HDL ratio 2.3, and LPIR of 6.4. There were 63 total cases of coronary heart disease in the less than 55 age group, which is a relatively low prevalence, so we can approximate hazard ratios by these odds ratios. Therefore, there is a 10.7 times greater risk, or a 970% increase in the risk of coronary heart disease developing before the age of 55 with a diagnosis of diabetes when compared to no diabetes. For LDL, this odds ratio is used in relation to the median LDL of the study of 130 and a standard deviation of 30, meaning an increase in LDL from a baseline of 130 to 160 portends an odds ratio of coronary heart disease before the age of 55 of 1.4. I chose to highlight these 5 risk factors, as 4 of these 5 are directly related to insulin resistance, and the other, which is LDL, is the most publicized risk factor of coronary heart disease. All 4 of these markers of insulin resistance that the study looked at had the highest odds ratio for coronary heart disease before the age of 55. However, the risk remained elevated even for above the age of 75. All risk factors decreased with age, likely due to the fact that age itself is a large risk factor for heart disease. The odds ratio of developing coronary heart disease at nearly any age was higher for nearly all markers of insulin resistance than for a standard deviation of increase in LDL of up to 160. The main point of this data isn't that we should not focus on LDL, but that we should give insulin resistance the considerable attention it deserves during our clinic appointments. What is a good marker of insulin resistance? This question is still being answered by active research. However, an easy test with good performance is the homeostatic model of insulin resistance, or HOMA-IR. This measure only requires a fasting insulin level and a fasting glucose level. It is simply a fasting insulin times fasting glucose divided by the correction factor, which is dependent on the units, in this case, 405. There are numerous calculators online, as this data will not be on any lab reports. As this is still an active research, there is a range of cutoffs for the transition from insulin sensitivity to insulin resistance. These are typically quoted as 1.6 to 1.9, with the Obesity Medicine Association landing on about 1.9. For an example of the extra information that the HOMA-IR conveys, imagine the management of a patient with a fasting fingerstick blood sugar of 90, which is relatively thought of to be adequate in clinic. However, their insulin resistance is dependent on their fasting insulin as well. Going from a fasting insulin of 5 to 10 to 30 correlates to a 6-fold increase in the HOMA-IR. This information will be lost without a fasting insulin and calculating the HOMA-IR level. Next, we'll discuss 3 studies that investigated the performance of HOMA-IR in 3 different populations. For this study, they investigated normal weight and obese children. This study had just over 2,700 subjects aged 2 through 18 years old, and a receiver-operator characteristic analysis was used to compare HOMA-IR accurately identifying subjects with any cardiometabolic risk factors, including total cholesterol and/or triglycerides greater than the 95th percentile, HDL under the 5th percentile, impaired glucose tolerance, and ALT levels greater than 40 units per liter. They concluded that the 75th percentile is an accurate representation to suspect more cardiometabolic risk factors in these populations. The 75th percentile for the entire population was 3, 1.7 in normal weight children, and 3.4 in obese children. This next paper compared the quantitative insulin sensitivity check index, HOMA-IR, fasting insulin, and fasting glucose alone in detecting insulin sensitivity. It had 191 obese children and adolescents. The area under the curve was identical at 0.8 for both quantitative insulin sensitivity check index and HOMA-IR. Both performed significantly better than fasting insulin and fasting glucose alone at detecting insulin sensitivity. This final study investigated adults with type 2 diabetes and compared different markers of insulin sensitivity with the gold standard hyperinsulinemic euglycemic clamp. Specifically, the investigators used the M value of the clamp, which is the total body glucose disposal rate and is a marker of insulin sensitivity. Below is the graph comparing M value to HOMA-IR. HOMA-IR was the most correlated marker of the M value, and it had a correlation coefficient of 0.572. The ultimate question is, how does obtaining a HOMA-IR in clinic to measure insulin resistance change our management? First, from this module, you have learned that considerable negative metabolic effects of insulin resistance, including end organ damage and worsening of nearly all primary outcomes. To quickly editorialize, I find this question of how does ordering X test change my management in outpatient medicine frequently means, what medication can I prescribe? This is one of my least favorite thought processes in medicine. At this point in time, there's no pill to counteract insulin resistance. However, more valuable than any single pill in outpatient medicine is our time as clinicians. As physicians, we have at least 7 years of training in medical school and residency to accurately convey the risks of disease and how to motivationally interview patients. And given that we only have a specific number of appointments per day, choosing to have close follow-up with a given patient weekly or monthly instead of yearly is a substantial change in management, worth more than any pill, especially if you can reverse their insulin resistance with good repeated counseling. For this counseling, we will discuss dietary interventions to reverse metabolic derangements in Module 4. Thank you for joining us for Module 3.